A very good evening to one and all. It gives me immense pleasure to welcome Dr. Sapthami S. Kauda. Presently, she is working as consultant intensivist at Sparsh Hospital, Yashwantpur, on behalf of Classroom Series. And Dr. Ponaya, who's our program director, we welcome you on this very important day, which is World Sepsis Day, where we all fight together to prevent and treat infection, ultimately resulting in better patient outcome. So today we'll be discussing a very important component of sepsis, which is the Surviving Sepsis Guidelines. Over to you, ma'am.
Yeah, thank you, Matangi. So today, on the pretext of World Sepsis Day, I'll be talking about the Surviving Sepsis Guidelines. So today, I'll be talking in detail about the Surviving Sepsis Guidelines, which was last updated in 2021. This is the most recent guidelines. So some history. So this Surviving Sepsis Guidelines was a collaboration guidelines between the European Society of Intensive Care Medicine, the Society of Critical Care Medicine, and the International Sepsis Forum. So it was initially launched in Barcelona in 2002, and the sepsis guideline, the first guidelines came out in 2004, and every 4 years it's been getting revised: 2008, 2012, and 2016. And consequently, even the bundles have been revised. So the initial bundle was in 2004, had a 6-hour and a 24-hour bundle. In 2013, it was a 3-hour and a 6-hour bundle. And because of the lot of criticism that was involving the 3-hour bundle and the 6-hour bundle, finally they came up with a 1-hour bundle in 2018. And in 2020, we had the pediatric sepsis guidelines and the COVID guidelines. And finally, the recent adult sepsis guidelines of 2021. I think the next guidelines, probably by this year and or next year, we will be getting the revised, updated guidelines. So, coming to the implications of recommendations, mainly for weak clinicians, most individuals should receive the recommended course of action. So when it says a strong recommendation, you should receive it without doubt. And formal decision aids are not likely to be needed to help individuals make decisions consistent with their values or preferences. But if it's a weak recommendation, then different choices are likely to be appropriate for different patients. So it is not tailor-made. I mean, you have each patient, it's different. And therapy should be tailored to the individual patient's circumstances, such as the patient's or family's values and preferences. Of course, they have different implications for the patients and the policymakers, but I'll be talking about the clinician part. So what is different about the 2021 guidelines? It gives a greater emphasis on panel diversity. The panel that was involved, it was diversified in terms of gender, geographical distribution, economic distribution. So a lot of different countries were involved. Questions were selected following international evaluation of practice and uncertainties. The PICO questions about long-term outcomes after sepsis were added. PICO wherein patient intervention, I for intervention, C for comparison or control, and O for outcome. So those kind of questions were involved. And use of evidence to decision framework, as a transparent and structured system for formulating the recommendations were done. So overall, in 2021 guidelines, we have 93 total recommendations, and of which there are newer recommendations like capillary refill time, empirical MRSA coverage, empirical fungal coverage. These are first time appearing in the 2021 guidelines, which were not there in the 2016 guidelines. So peripheral vasopressor use, levosimendan, HFNC and NIV use of ECMO, and post-ICU follow-up. So these are all the newer recommendations. So before jumping into the guideline, I just wanted to brief about the bundle. So how it evolved. So the 2005 had a 6-hour and 24-hour bundle, and 13 it was a 3-hour and a 6-hour bundle. So currently we have a 1-hour bundle which we follow, which says you have to measure serum lactate, remeasure it if the initial lactate is more than 2 millimole per liter, and obtain blood cultures prior to antibiotics, followed by broad spectrum antibiotics administration. Consequently, even begin resuscitating with rapid crystalloids at 30 ml per kg, and you have to use vasopressors if hypotension remains after fluid resuscitation to maintain a MAP of more than equal to 65. So this was an interesting study by Levy et al. So it saw the association between the performance metrics and the outcomes, okay, in terms of the bundle in a 7.5-year study. So there they saw that by improved bundle compliance, by following the bundles, there was a 25% decrease in the mortality. So it's very important that we have a good compliance with the bundle. Coming to the sepsis definition. So the recent definition is the sepsis 3.0 definition. So there they define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Organ dysfunction itself can be identified as an acute change in total SOFA score of more than equal to 2 points consequent to the infection. And septic shock is defined as a need for administration of vasopressor medication to maintain a MAP of at least 65 Hg and serum lactate more than 2 millimole per liter in the absence of hypovolemia. So this is a recent definition. So of note is that, if you compare it to the 2001 sepsis and the earlier definitions, if you see, there were three definitions of sepsis: sepsis, severe sepsis, septic shock. The recent sepsis 3, the severe sepsis is done away with, and only you have the sepsis and the septic shock. So coming to the guidelines, first they talk about the screening and the early treatment. So screening for patients with septic and septic shock. For hospitals and health systems, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients and standard operating procedures for treatment. So before I forget, I want to just let you know that wherever there is a green exclamatory mark, double exclamatory mark, it means it is a strong recommendation. If it is single exclamatory mark, it is a weak recommendation. Okay, and if it's a red exclamatory mark, it is a recommendation which goes against, and these are for. Okay, and wherever there's a best practice statement, it is marked by a star. So coming to the screening of for patients with sepsis, you have a strong recommendation with moderate evidence. So, and also compared to the 2016 statement, what is the new thing that has been added is SOPs, that is standard operating procedures for treatment, were not added in the previous guideline, but that has been added now. So if they talk about sepsis performance improvement program, they refer to sepsis screening program, screening programs, education programs at hospital level, measurement of sepsis bundle performance, etc. And this leads to better adherence to the sepsis bundles and also better mortality reduction. Okay, there are various sepsis screening tools, but we recommend against using QSOFA compared to SIRS, NEWS, or MUSE. That is, NEWS is National Emergency Warning Score, or Modified Emergency Warning Score, as a single screening tool for sepsis or septic shock. For adults suspected of having sepsis, we suggest measuring blood lactate. You have to note that the second recommendation is a new recommendation that has been added, and initially this has also been changed from a best practice recommendation in 2016 to a strong recommendation. Okay, so here they're saying that the QSOFA score that involves 3 points, that is respiratory rate more than 22, altered mentation, that is a GCS less than 15, or a systolic BP less than 100. 2 out of 3, that means QSOFA is predicts higher death and higher mortality. But QSOFA as a screening tool, it's a very poor indicator. Okay, and the sensitivity is low, and it is not a very sensitive test as a screening tool. The better screening tools like SOFA score, of course, it is more cumbersome to use bedside because there are multiple variables involved, like respiratory, cardiovascular, liver, renal parameters, coagulation parameters, neurological. It is not as simple as QSOFA, but it's got a better sensitivity for sepsis screening. And the modified early warning score, the MUSE and the NEWS, these are also the better screening tools compared to QSOFA. Come to lactate. Lactate is a part of the 1R bundle, as I already mentioned, and that's part of the sepsis 3 definition. And the cutoff will range from 1.6 to 2.5 millimole per liter. Sensitivity will range from 66 to 83 and specificity of 80 to 85. So we have seen among the studies there is an inconsistent association between the lactate measurement and reduced mortality. And also, while always looking at lactate in terms of sepsis, we have to take into account the clinical profile and the context of the in which you're seeing the patient. For example, if you are seeing a patient with a chronic liver disease or a liver involvement, then obviously lactates can be high. Or a patient with severe hypovolemia because of gastroenteritis, where fluid loss is there, again lactate can be high. Or a patient or oral hypoglycemic agents like metformin, in such patients lactate can be high. So you have to look at the clinical context always while interpreting lactate. And also, one more drawback of lactate is its limited availability in resource limited settings. So many places wherein lactate might not be available at the bedside. So hence, it is not a very strong recommendation. Coming to the initial resuscitation, the best practice statement here: sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation should begin immediately. So no doubt about this, it should be begin immediately, and it is a best practice statement. The next, we say that for patients with sepsis-induced hyperperfusion or septic shock, they suggest at least 30 ml per kg of IV crystalloid to be given within first 3 hours of resuscitation. So what was the previous 2016 guideline statement that said? It said we recommend. Okay, the word recommend was used, and now that has been replaced by the word suggest. Okay, it is no more a strong recommendation. And if you also see, initially it was a 2 exclamatory mark, which is a strong recommendation. Now it has been changed to a weak recommendation. Okay, and also for adults with sepsis or septic shock, we suggest using dynamic measures to guide the fluid resuscitation over physical examination or than using static parameters. Also, they suggest guiding resuscitation to decrease serum lactate in patients with elevated lactate level over not using serum lactate at all. So that can be used as a marker to guide resuscitation. And again, it is a low, all these are weak recommendations, whether using dynamic indices, whether using lactate for resuscitation, and also using one more newer recommendation that has been added in 2021 is a capillary refill time. So we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. But again, it is a weak recommendation with low quality evidence. So if you see why the magic number 30 ml per kg from the old 2001 EGDT, that is a Reverse et al. Paper which was initially published. So this 30 ml per kg crystalloid has been carried over the all the RCTs, but there is no prospective intervention studies further which compare different volumes for initial resuscitation sepsis or septic shock. So we don't have an exact number, but there this comes with the risk of fluid overload, prolonged ventilation because of ARDS patient can land up in increased AKI and mortality. And always you have to remember that dynamic measures, I mean to say passive leg raising test coupled with cardiac output measurements like VTI, SVV, or cardiac output monitoring, PICO, those are dynamic end expiratory occlusion test. These are dynamic measures of fluid resuscitation. And fluid challenges, they have to be used against static measures. What are static measures? Like heart rate, BP, checking the urine output and giving fluids, or CVP or SCVO2, central venous oxygen saturation, or even lung ultrasound, or even echo for that matter. They are not real-time indices. They are static indices. So whenever we talk about resuscitation, you have to remember that initial fluid resuscitation, which happens in the ED, here you should not apply this dynamic indices of fluid resuscitation. These come into picture only in the ICU when the resuscitation is continued. The initial management, fluid management, which happens in the emergency, there, irrespective of the fluid responsiveness, initial fluids have to be given in septic shock. Later only the concept of fluid responsiveness comes into picture. Coming to the sepsis triology, so I already spoke about the Reverse et al. Trial of 2001, which promoted the concept of EGDT with the 6 hours protocol, which involved a lot of tasks to be done. Post that, in 2015 came the Process, Arise, and the Promise trials. These were the 3 consecutive trials that came. They all compared the early goal-directed therapy, that is EGDT therapy, versus a standard therapy care, which they were following as a control. And they found all the 3 trials did not find any difference in 90-day mortality by comparing the EGDT versus standard therapy. In fact, there was increase in the IV fluids and vasopressors in the EGDT group compared to the regular standard therapy group in the first 6 hours. And of course, the recent classic trial and the Clovers trial. The classic trial, which came out in 2022, and there they investigated whether restriction of IV fluid in the ICU in septic shock patients improved the 90-day survival. So they compared a restrictive fluid group versus standard fluid group, and they concluded that in adult patients with septic shock, IV fluid restriction did not result in fewer deaths at 90 days than standard IV fluid therapy. So restrictive fluid therapy, there was no mortality benefit. Again, in 2023, we had a Clovers trial. In the Clovers trial, they compared the restrictive versus liberal fluid management. And in the restrictive fluid, there was early use of vasopressors along with fluids. So they concluded that a restricted fluid approach, prioritizing vasopressors, did not improve the mortality in patients with sepsis-induced hypertension. So there was either way no mortality benefit. Then one more important trial which I would like to talk, because we're talking about capillary refill time, is Andromeda shock trial. So this compared the effect of resuscitation strategy targeting peripheral perfusion status using parameters like CRT versus serum lactate levels in septic shock. So there they concluded that among patients with septic shock, a resuscitation strategy targeting normalization of CRT, Okay, compared with a strategy targeting serum lactate levels did not reduce all-cause mortality. Okay, so it was comparable. There was no mortality benefit, but still they have recommended CRT, especially CRT requires. Doesn't require point of care testing like lactate, and also in resource limited settings it is more easier to use, it is more easily available, and it being done quickly at the bedside. But of course the clinical profile of the patient should be taken into picture, and that alone should not be relied upon for fluid resuscitation. That should be combined with other indices of fluid resuscitation. Coming to mean arterial pressure. For adults with septic shock and vasopressors, we recommend an initial target MAP of 65 over higher MAP targets. So this was a strong recommendation with moderate quality evidence. This has been unchanged compared to the previous guidelines. It's the same thing which has been carried forward. And how did we get this number of 65? Basically, it was based on the sepsis spam trial. It was in 2014. So there they compared two groups. That is one group with the lower MAP and higher MAP. Lower MAP was 65 to 70, and the higher MAP group was around 80 to 85. And they saw that both did not have, in between the groups, when they saw this, there was no mortality benefit. But in a subset analysis, where they saw patients with chronic hypertension, they saw that maintaining a slightly higher MAP in these patients, there was reduced incidence of RRT in these patients. So following this came the 65 trial. So here they involved only patients more than 65 years of age in the ICU who were septic. So here they use a permissive hypotension, that is MAP of lesser MAPs of 60 to 65. Again, there was no mortality benefit, but what they saw that there was no harm that was done to these patients in the 65 trial. So if a midway has to be chosen between these two trials, then 65 is a more appropriate number. So the panel recommends targeting a MAP of 65 in the initial resuscitation of patients with septic shock, which requires vasopressors. Coming to admission to ICU. For adults with sepsis or septic shock who require ICU admission, we suggest admitting the patients to ICU within 6 hours. Because again, there are no major RCTs to define the exact time frame, but there are smaller studies. And one thing among the studies that is very commonly seen is that increase in the time from admission from ER to ICU, there is increase in the mortality. So delayed ICU admission is shown in various studies, leads to long ICU stay, prolonged ventilation, and high mortality. Now, next coming to infection. So as you can see, it's a best practice statement. For adults with suspected sepsis, septic shock, but unconfirmed infection, we recommend continuously re-evaluating and searching for alternative diagnosis and discontinuing the empirical antibiotics if an alternative cause of illness is demonstrated or strongly suspected. So for adults with possible septic shock or a high likelihood of sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour. So if it's a proven septic shock, okay, then definitely it's a high grade recommendation. Again, it's a low evidence, it has to be given within 1 hour. Sepsis without shock, but still there is a possibility, then a probability, then you have to go ahead and give it within 1 hour. Compared to the 2016 statement, which is also high grade recommendation, it said that antimicrobials, IV antibiotics should be initiated irrespective of whether there is septic shock or sepsis without shock. It has to be given in 1 hour. And one more best practice statement is that for patients with possible sepsis without shock, we recommend rapid assessment of the likelihood of infection versus non-infectious causes of acute illness. So first, if you think it is possible sepsis, but there is no shock, first you have to evaluate for the cause of the acute illness. And still after that, we suggest a time-limited course of rapid investigations. And if concern for the infection still persists, then you have to administer antimicrobials within 3 hours from the time when sepsis was first recognized. Again, the 2016 guidelines did not give any clarity. It just said that you give it within 1 hour antibiotics if it's septic shock or sepsis without shock. For adults with a very low likelihood of infection and there is no and without shock, we suggest deferring antimicrobials while continuing to closely monitor the patient. So if you don't think that the sepsis is the cause and there is no shock, then we can wait to give the antibiotics. So to just sum up the in a table, so either shock is present and shock is absent. If shock is present, then excuse me. Yeah, if shock is present, then sepsis is definite or probable. Then you administer antimicrobials immediately, ideally within 1 hour. Okay, and if shock is present and sepsis is still a possibility, okay, after administering you can still administer antibiotics within 1 hour. But if shock is absent and the sepsis is a possibility, then you have to go for a rapid assessment to see if it's an infectious or a non-infectious cause. And still, if you feel that sepsis could be a possibility, up to 3 hour time frame from the time sepsis was first diagnosed, you can give antibiotics. So, as a best practice statement, we recommend that appropriate routine microbiological culture should be obtained before starting the antimicrobial therapy with suspected sepsis and sepsis shock. This we already saw in the 1 hour bundle. But if it results in no substantial delay in the start of the antimicrobial, so if you want to start antimicrobials, ideally you have to send blood culture, but you have to see to that the antimicrobials should not be delayed. Ideally, less than 45 minutes, you have to give the antimicrobials. Coming to biomarkers to start antibiotics, this is against recommendation with very low quality evidence. So we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. So they clearly say that using procalcitonin to initiate antibiotics is a big no. And this has been proven with many meta-analysis. So it is we had a meta-analysis of 30 studies, and procalcitonin had a pooled sensitivity of 77% and a specificity of 79% for sepsis in critically ill patients, and 3 RCTs comparing procalcitonin guided protocol for antibiotic initiation versus the usual care, that is no procal was used. No difference in short-term mortality, length of ICU stay, or length of hospitalization. So for initiating antibiotics, procal has no use. Coming to the antimicrobial choice. So these are newer recommendations which has been added in the 2021 guidelines. So the 2016 guidelines was very vague. It just said that they recommend empiric broad spectrum therapy with one or more antimicrobials for patients which present with sepsis or septic shock to cover all the likely pathogens. Okay, they were very vague. They did not mention clearly what kind of organisms we have to target. So the best practice statement for patients with high risk for MRSA, we recommend using empiric antimicrobials with MRSA coverage over using antimicrobials without MRSA coverage. So if there are risk factors for MRSA, definitely we have to start empiric MRSA coverage. And if we said if they are at a low risk for MRSA, they suggest against using empiric antimicrobials with MRSA coverage as compared to using antimicrobials without MRSA coverage. So what are the risk factors for MRSA? MRSA meaning methicillin-resistant Staph aureus. So the risk factors are prior history of MRSA, infection or any colonization any other site, recent IV antibiotic use with history of recurrent skin infections or chronic wounds, presence of invasive devices like hemodialysis, EVD catheters, recent hospital admissions, and increased severity of illness. So these are all our risk factors for MRSA. Coming to MDR organism, multi-drug resistant organisms. So it is a weak recommendation with low evidence. As you can see, patients with septic shock and high risk for MDR, they suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative. So they're telling to use 2 antibiotics which cover GNBs. And for adults with low risk for MDRs, they suggest against using 2 gram-negative agents for empiric treatment as compared to 1 gram-negative. So you can just use 1 if there is a low risk for MDR. And they suggest against using double gram-negative once a causative organism is known and the susceptibilities are known. So once you get the culture reports, then you can de-escalate and narrow down your antibiotics. So in the empiric phase, based on the local prevalence, that is your antibiogram, based on what are the resistant organisms in your ICU, patient risk factors for resistant organisms, and the severity of the illness, you start with a broader spectrum, 2 antibiotics. In the directed or the targeted phase, that once the organism is known, sustained double gram-negative is not necessary. But supposing it's a very resistant organism, then maybe sometimes you might require a double gram-negative coverage. And meta-analysis of around 10 RCTs did not show any benefit of mono versus combination therapy in severe sepsis, septic shock. But sometimes if a resistant organism, we'll have to give double coverage. Again, the risk factors for MDR infection, proven infection or colonization with this antibiotic resistant organism in the preceding year, and local prevalence. There's an antibiogram shows any resistant organisms, hospital-acquired infections. Those are more risk for MDR than community-acquired organisms. Broad spectrum antibiotic use in the preceding 90 days, that is 3 months. Concurrent use of SDD, selective digestive decontamination, oral or systemic, then travel to highly endemic country within the preceding 90 days, and hospitalization abroad within the preceding 90 days. So all these are risk factors, and these patients require empirical MDR therapy. Coming to antifungal therapy, they say that patients at high risk for fungal infections, they suggest starting empiric antifungal or no antifungal. And again, if they're low risk, they suggest against it. Again, the 2016 statements are very vague. They never spoke about when to start antifungal, MRSA, MDR. So those vague statements only are continuing. Coming to the risk factor for Candida sepsis. So when do we say Candida sepsis? A probability when Candida colonization at multiple sites, 2 or more sites, when you get Candida albicans, that shows colonization. Surrogate markers like serum beta D glucon assay, neutropenic patients, immunosuppressed patients, high Apache score patients, long length of ICU stay with indwelling lines, and drug abusers, patients on TPN, especially post-surgical patients with long-term broad-spectrum antibiotics, GI surgeries, okay, with anastomotic leaks, emergency GI surgeries, hepatobiliary surgeries, acute renal failure, dialysis patients, thermal injuries, grade 2, 3 burns, or any prior surgery patients for a long time, they might require Candida cover. Coming to risk factors for yeast, endemic yeast infections, which includes Cryptococcus, Histoplasma, Blastomyces, and Coccidioidomycosis. These are quite rare, but for this, you should have an antigen marker which is positive. HIV infection, again, solid organ transplant and hematopoietic stem cell transplant, high dose steroid therapy, uncontrolled diabetic patients, and certain biological response modifiers. Risk factor for invasive mold infection. So invasive mold infection includes aspergillosis and mucormycosis. Again, the neutropenic patients are at high risk, solid organ, hematopoietic stem cell transplant patients, and surrogate markers such as the serum or BAL galactomannan positive, high dose steroids, and certain biological response modifiers. So in such patients, we have to cover for mold infections. So just to mention the Empiricus trial. So among the non-neutropenic patients, which we see majority of them in the ICU, okay, which have acquired ICU-acquired sepsis, that is hospital-acquired, Candida species colonization at multiple sites and multiple organ failure with empirical treatment with micafungin compared with placebo did not increase fungal infection-free survival at day 28. So empirically starting for all such patients with micafungin did not show any benefit or mortality benefit at day 28. Coming to the delivery of antibiotics and pharmacokinetics and pharmacodynamics. So they may, and by the way, they do not make any recommendations on the use of antiviral agents. But of course, when do we start antiviral agents? Again, stem cell hematopoietic stem cell transplants, solid organ transplants, immunosuppressed patients who rarely have this HSV, cytomegalovirus. Those are the patients where you will cover with antiviral. Otherwise, regularly, they're not used. Then coming to patients with sepsis septic shock, coming to PKPD, we suggest using prolonged infusion of beta-lactams for maintenance after an initial bolus over conventional bolus infusions. And for best practice statement, we recommend optimizing the dosing strategies of antimicrobials based on the accepted pharmacokinetic, pharmacodynamic principles and specific drug properties. So PKPD properties of the drug have to be taken into consideration. Some are time-dependent antibiotics, some are concentration-dependent antibiotics. So that has to be taken into consideration. And prolonged infusions of beta-lactams help in maintaining the steady-state concentrations, and they are preferred than intermittent infusions. Coming to source control, so these are best practice statements. So we recommend rapidly identifying and excluding the specific anatomical diagnosis of infection that requires emergent source control and implementing any required source control intervention as soon as medically and logistically practical. So we should go for source control as soon as possible. One more thing is we recommend prompt removal of any intravascular access devices that are possible source of sepsis or septic shock after other vascular access has been established. So source control, wherein after the initial resuscitation, there are not many studies which tell what is the ideal time to source control after resuscitating the patient, but there are few studies which say up to 6 hours. Okay, up to 6 hours after resuscitation is an ideal time to take for early source control, wherein like it could be an intra-abdominal abscess, or it could be a pyelonephritis, or an ischemic bowel, or a volvulus, a perforated bowel, or wound debridement. So these are places where you will go for source control. Coming to de-escalation of antibiotics. So these are all weak recommendations with low quality evidence, and they suggest daily assessment for de-escalation of antimicrobials over using fixed duration of therapy without daily reassessment of de-escalation. So every day we have to, even though we start empirical antibiotic, we always have to, every day we have to see if there is a scope to de-escalate the antibiotic. It is part of the antibiotic stewardship policy which we have to follow. So for adults with an initial diagnosis of sepsis or septic shock and adequate source control, we suggest using shorter over longer duration. So again, we have to use shorter antibiotic courses than longer antibiotic courses. And for adults with an initial diagnosis of sepsis or septic shock and adequate source control, where optimal duration of therapy is still unclear, we can use procalcitonin and clinical evaluation, and that will help to decide to discontinue the antimicrobial over clinical evaluation alone. So even though sometimes cultures are negative, you have to de-escalate the antibiotic because patient is clinically improving, and that time you can use procalcitonin along with clinical evaluation. Coming to fluid management. So one strong recommendation with moderate quality evidence is we recommend using crystalloids as a first line fluid for resuscitation. That is very clear in 2021 guidelines. So balanced crystalloids are the go-to fluids for resuscitation. Rest all are weak recommendations with low quality evidence. The 2016 guidelines said we suggest using either balanced crystalloids or saline for fluid resuscitation. So there was an option between the two. They were not very clear on the type of fluid that has to be used. But the 2021 guidelines clearly say we suggest using balanced crystalloids instead of normal saline for resuscitation. So as you already know, there are some side effects of using normal saline, which I'll be discussing later. And again, they say that we suggest using albumin in patients who have received large volume of crystalloids. It's a weak recommendation. So some patients require very large quantities of crystalloid, then albumin can be used to replace the fluid just to add up to the volume. And against very high recommendation, very high quality of evidence also is for patients with sepsis or septic shock, we recommend against using starches for resuscitation. That they're very clear not to use starch at all for resuscitation. And another thing is we suggest against using gelatin for resuscitation. So these two things are very clear. So in the previous also they had made it that we suggest using crystalloids over gelatins, but now they have suggested against gelatins itself. So coming to the side effects of normal saline. So as you know, it causes hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and AKI. So increased incidence of AKI. So one important trial recently which has come out is BASICS trial. The use of balanced crystalloids compared to 0.9% NS did not reduce the 90-day mortality. So there was no mortality benefit that was seen. And of course, you know, there were a lot of trials that were done on normal saline versus balanced crystalloids. The most important being the split trial, the SALT ED trial, and the SMART trial. The split trial, there was no difference in rate of AKI between the two. SALT ED trial, again, it was a small cluster of patients which was done in the ED. Normal saline increased the renal injury in these patients compared to RL. And the SMART trial, again, the NS increased the composite of death or an AKI was compared to the balanced fluid. Then one more important study with term in respect to albumin is SAFE study. Overall, there is no difference when 4% albumin is used for fluid resuscitation when compared to 0.9% NS. And 4% albumin should be avoided in head injuries. In a subset analysis, they saw that the mortality was high if they use albumin in head injury patients. So after this came the Albios study. This Albios study, they saw the albumin replacement in patients with severe sepsis or septic shock. So here they concluded that among patients with severe sepsis or septic shock, daily administration of albumin to maintain an albumin of more than equal to 3 was not associated with reduction in the all-cause mortality at 28 days when compared to no albumin. So using albumin, the sole purpose of increasing the albumin had no mortality benefit. With a very weak recommendation, it could be used when already you have surpassed the quantity of crystalloids that you use for resuscitation. Just to add volume, sometimes you can use it for resuscitation, but not to increase the albumin level. Coming to HES and hetastarch and gelatin, there are enough RCTs and all of them are negative trials. Hetastarch has shown increased risk of renal replacement therapy and death, and gelatin, there is increased anaphylactic risk. It affects the hemostasis, increases the RRT, and increases the mortality. So these two should definitely be not used in the resuscitation. So coming to the evolution of resuscitative fluid selection, you know, if initially we were giving blood, then later hetastarch, then normal saline. Now we have come towards balanced crystalloids, and of late we have started talking about pH guided resuscitation. That is, you see the pH and you tailor the IV fluids based on the patient and the pH. So that is pH guided resuscitation. That is where the newer resuscitation is heading towards. Coming towards vasoactive agents. So we recommend using norepinephrine as a first line agent over other vasopressors. Again, it is a very strong recommendation with high quality evidence. And apart from that, there is some high level evidence for dopamine, moderate evidence for vasopressin, but epinephrine there is low evidence, celepressine low evidence, and angiotensin 2 there is very low evidence. For patients with shock on norepinephrine with inadequate MAP, we suggest adding vasopressin instead of escalating the dose of norepinephrine. This is a weak recommendation. Is if in patients with septic shock and inadequate MAP, despite norepinephrine, vasopressin, the third inotrope they suggest adding is epinephrine. This is a low evidence. And for patients with septic shock, we suggest against using terlipressin. So not much role of terlipressin in ICU, definitely not as a vasoactive agent. Then for adults with septic shock and cardiac dysfunction, because sepsis-induced myocardial dysfunction is very common in septic shock patients. If there is persistent hyperperfusion in such patients, in spite of volume status, they suggest adding dobutamine or epinephrine, okay, to norepinephrine to improve the cardiac dysfunction as an inotrope. And for adults with septic shock and cardiac dysfunction, there is definitely no evidence for levosimendan. They suggest against levosimendan. It's a calcium sensitizer and it has not much role. Also, they suggest using IBP, that's invasive monitoring, over non-invasive monitoring, as it is more practical and if the resources are available. Coming to the newer recommendations, one important thing to note here, this new recommendation has come in 2021. They suggest starting vasopressors peripherally to restore the MAP rather than delaying initiation until a central venous access is secured. So very important, most of hospital settings, sometimes we wait for central line to start inotropes. That should not be the case. So you can start the vasoactive agents in the peripheral line also, provided it is a good wide bore cannula, which is proximal to the antecubital fossa. Then you can start the vasopressors in the peripheral line itself. And if it's a short time, that approximately less than 6 hours, then you can give vasoactive agents in the peripheral line. 2016 statement, they were very vague. Again, they suggested using either balanced crystalloids or saline for fluid resuscitation, and they just said you can't use crystalloids or gelatin. Other than that, they didn't talk much about vasoactive agents. And one more thing is regarding liberal and restrictive fluid strategy. I'll talk about it later. So this is a chart for vasoactive agent management. So two things are of high, strong recommendations you have to remember. Using norepinephrine as a first-line vasopressor. That is the strong recommendation. And another strong recommendation is targeting a MAP of 65. So there is no doubt in these two. Rest all are weak recommendation. That is considering invasive monitoring of arterial blood pressure. And if central line is not available, you can initiate vasopressors peripherally. And if MAP is inadequate despite norepinephrine, which is low to moderate dose, you can add vasopressin. And if there is cardiac dysfunction concomitantly, you can add dobutamine or you can switch to epinephrine. But you have to remember that when using dopamine and epinephrine, there is a risk of arrhythmias. And epinephrine, in fact, increases lactate production via beta-2 receptors. So you can have some false positive high lactates in the ABG. So whenever you're using epinephrine, lactate cannot be a very good indicator of sepsis. Okay. Then two important trials are VANISH trial and VAS trial. VANISH trial that compared vasopressin and norepinephrine. There was no difference in 28-day mortality. But they saw that the incidence of RRT was less with the vasopressin use. Next is the VAS trial. VAS trial compared norepinephrine versus norepinephrine and vasopressin. There was no mortality benefit, but there was increased survival in the norepinephrine vasopressin group. So when do you start vasopressin? So in the remarks column, they've added that starting vasopressin when norepinephrine dose is in the range of 0.25 to 0.5 mics per kg per minute seems sensible. So approximate to that dose, but there is no guidelines on that. But in the remarks, they've added that at this dose, you can think of initiating vasopressin. There is no evidence for dobutamine superiority over epinephrine in cardiac dysfunction. Both are comparable. Next, coming to the ventilation. One more thing is regarding restrictive versus liberal fluid strategies in the first 24 hours of resuscitation. Already I've spoke about it. So in patient septic shock, there is insufficient evidence to say that one is more beneficial than the other. Both are comparable. But of course, restrictive maybe after the initial fluid resuscitation based on the dynamic indices and other parameters of fluid responsiveness will be a better approach. Coming to ventilation, so there is insufficient evidence to make a recommendation on the use of the conservative oxygen targets in adults with sepsis-induced hypoxic respiratory failure. So the oxygen targets are not well defined. For adults with sepsis-induced hypoxic respiratory failure, we suggest the use of high-flow nasal oxygen over NIV. Okay, this is a newer recommendation. Again, it's a weak recommendation, and again, there's insufficient evidence to make a recommendation on the use of NIV in compared to invasive for adults with sepsis-induced hypoxic respiratory failure. So high flow has a more greater advantage than NIV, especially because the patient interface is more comfortable for the patient, and especially in type 1 respiratory failure, it is more comfortable, and the other complications of NIV can be avoided. NIV, there's a risk of gastric insufflation, patient can feel claustrophobic, pressure sores can occur, and risk of aspiration is there. But these pointers are not there in HFNC. But one thing about HFNC, obviously, you cannot decrease the work of breathing, and adequate PEEP cannot be provided with HFNC compared to NIV. Then one more very high strong recommendation, high quality evidence is for adults with sepsis induced ARDS. We recommend using a low tidal volume strategy, that is 6 ml per kg over a high tidal volume more than 10 ml per kg. Actually, the ventilation guidelines are almost in par with the ARDS net protocol, so almost similar guidelines are there. Coming to the plateau pressure, we recommend using upper limit goal for plateau pressures of 30 centimeter water over higher plateau pressures. So up to 30 is the upper limit. Again, it's a strong recommendation. Rest all are weak. Then we suggest using high PEEP over low PEEP. And also, they suggest using low tidal volume as compared to high tidal volume in sepsis-induced respiratory failure without ARDS. Even with ARDS, also low tidal volume. Overall, in septic shock patients, low tidal volume is more preferred compared to high tidal volume. For adults with sepsis-induced moderate to severe ARDS, we suggest using traditional recruitment manuals. So there is some weak recommendation to use the recruitment manuals, but there is a very strong recommendation to against using incremental PEEP titration or strategy technique. So the incremental and the decremental PEEP titration strategy which we use for recruitment can result in volume trauma, barotrauma, and also there are many studies to show that it increases the mortality. So that should not be followed. And for adults with sepsis-induced moderate to severe ARDS, we recommend using prone ventilation for greater than 12 hours daily. This is part of the PROSIVA trial that showed that in moderate to severe ARDS, if it is early, less than 36 hours, proning can be done for more than 16 hours. And there was a definite mortality benefit because it increases the lung ventilation and compliance. And for adults with sepsis-induced moderate to severe ARDS, we suggest using intermittent neuromuscular blockers over continuous infusion. Than giving continuous, using light sedation with intermittent neuromuscular blocker agents is more useful. And for adults with sepsis-induced severe ARDS, we suggest using veno-venous ECMO when conventional mechanical ventilation fails in experienced centers with the infrastructure in place to support it use. So coming to the oxygen targets, two important trials to remember. When you talk about conservative oxygen target, it's usually a PaO2 targeting a PaO2 of 55 to 70 or a saturation of 88 to 92. So usually in our COPD, ILD patients in our medical ICU, we target a saturation of 88 to 92 in these patients. Coming to the ICU ROX trial. So during the first 28 days in the ICU, it saw that the conservative oxygen therapy as compared to the usual oxygen therapy did not significantly affect the number of ventilator free days. So there was no mortality benefit. The oxygen ICU was one more trial for critically ill patients with ICU length of stay of more than 72 hours. They followed a conservative versus a conventional protocol for oxygen therapy, and the conservative resulted in a more lower ICU mortality, but it was a single center RCT. In MI patients, you have 2-3 trials. Avoid trial wherein conservative approach is preferred, conservative oxygen therapy is preferred. But why high FiO2s have to be avoided? Because of the free radicals and the oxidative damage that can occur. Coming to ventilation, that is the high flow nasal oxygen. So the Florali trial. Florali improved in this Florali trial. It improved a 90-day survival with HFNC compared to NIV, and also HFNC patients experience significantly more days free of mechanical ventilation. So ventilator days had reduced in HFNC compared to NIV. Also, HFNC resulted in lower intubation rates compared to NIV. So it's a positive trial for HFNC. And the Prosiva trial, as I already spoke about it. Coming to the neuromuscular blockers, the Accuracy trial was a positive trial, and it showed mortality benefit with the use of neuromuscular blockers. But the Rose trial, which came recently, it said that continuous neuromuscular blockade infusion resulted in did not show any mortality benefit. And also, it reduces. Why do we use neuromuscular blockers in ICU? Because it reduces the risk of barotrauma, and patient ventilator asynchrony and all is reduced. But the effect on ventilator free days, duration of mechanical ventilation, ICU acquired weakness were not clear in the study. Because more use of neuromuscular blockers, the incidence of critical illness neuropathy is much high, and again weaning becomes a problem. So the recommendation is such that intermittent boluses with light sedation can be given than giving continuous infusions. Coming to ECMO, the Eolia and the Caesar trial were the trials which were done in the last 10 years. Caesar trial, wherein patients were actually, they were referred to an ECMO center, and Eolia trial where the ECMO was actually done. But again, there's not much mortality benefit in either of the trial. ECMO can be done, but it comes with a cost of correct, accurate patient selection has to be done. The cost is a big factor, and the availability. It is still not available in all centers, but still ECMO is an option that can be done in refractory ARDS. Coming to additional therapies. So for adults with septic shock and an ongoing requirement for vasopressor, we suggest using IV steroids. Okay, it's a weak recommendation. Previous statement, the 2016, they said that we suggest against using IV hydrocortisone to treat septic shock patients if adequate fluid resuscitation and vasopressor are able to restore the hemodynamics. If this is not achievable then only we suggest IV hydrocortisone dose of 200 mg per day. But in the newer guidelines, they are suggesting to use corticosteroids. It's a weak recommendation. So the dose suggested is 200 mg per day, and that is given as 50 mg IV every 6 hours or as a continuous infusion. So it is suggested to commence at a dose of norepinephrine or epinephrine of more than 0.25 mics per kg per minute at least 4 hours after initiation. So after 4 hours of initiation, still shock is not getting better with fluids and vasopressors, then it is time to add the steroids. But this time is not defined by the guidelines. It is just a remark. And steroids lead to shock reversal. They decrease the vasopressor need. They increase the ventilator free days, and they lead to less time in the ICU. So there are consistently secondary outcomes are seen among most of the trials. So there is a benefit in terms of secondary outcomes with respect to steroids. So if you look at the timeline of steroids, initially in 1976 was the first RCT on the high dose of steroids in septic shock. Then the landmark Anane trial came down in 2002. Then the Corticosteroids trial. Then in the 2016 there was a Hypress trial, followed by the recent trials in 2018, that was the Adrenal and the Approaches trials. So coming to the Adrenal trial, they saw that patients with septic shock requiring vasopressors and mechanical ventilation, they were randomized to hydrocortisone group and placebo group, and they saw that in patients with septic shock and mechanical ventilation and who are receiving vasopressors, a week of hydrocort of around 200 mg per day did not reduce 90-day mortality, but it may be associated with shorter time to reversal of shock, time to extubation, and length of ICU. So as I said, secondary outcomes, there is a positive this thing in all the trials, but overall mortality benefit is not there. Then you had the Approaches trial where hydrocort plus oral fludrocort was tried for patients with septic shock. Here they showed that hydrocort and fludrocort combination showed a mortality benefit and resolution to shock. And also it was safe, and hyperglycemia was noted as a common side effect. But the guidelines does not talk about fludrocort, it only talks about hydrocort. Then for patients with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion. In 2016, there's a newer guideline. In 2016, they made no recommendations regarding the use of any blood purification techniques or extracorporeal techniques. Again, in the current guidelines also, there is insufficient evidence to make a recommendation on the use of other blood purification techniques, be it plasma exchange or other hemoperfusion techniques. So there is not much evidence. There are no bigger RCTs. Much evidence is still needed. Then for adults with septic shock, we recommend using a restrictive over liberal transfusion strategy. So the transfusion trigger that has to be followed, we follow around 7 in the ICU. So there are some evidence, is a moderate evidence, is a strong recommendation that restrictive strategy is much better than the liberal strategy because it avoids all the complications that come with the blood transfusions. Then for adults with sepsis or septic shock, we suggest against using IV immunoglobulins. Again, it's a weak recommendation. There is not much evidence or trials on immunoglobulins. It is cost effective, not available everywhere, and we don't know the mortality benefits, so it is not used widely. Coming to stress ulcer prophylaxis, I'll be talking later. So, going to blood transfusion. So, two important trials, the TRIS and the TRIC trial. The TRIC was a landmark trial. It came in 2014. So, there they compared two groups. That is, one group with a restrictive approach where they targeted a hemoglobin of 7, and the other was the targeting a hemoglobin of 10. So, they saw that there was no benefit, but there were more complications in the liberal group. That is transfusion associated reactions, the TRALI, TACO, and other transfusion associated reactions for more. Same in the TRIS trial, the compared 7 milligram per DL versus 9 milligram, restrictive versus liberal. There was no mortality benefit, but still the guidelines, they endorse a restrictive transfusion strategy because there are lesser transfusion reactions. We can save resources. Blood is an important resource; it should not be wasted, and of course, the cost can be saved. So unless there's an indication, in few patients like ongoing cardiac ischemia, then traumatic brain injury patients, or ongoing hemorrhage, such patients, we have to this thing for a higher transfusion trigger. But otherwise, in critically ill ICU patients, you can go for a 7 milligram per deciliter target. Coming to the stress ulcer prophylaxis. Stress ulcer prophylaxis. So it's a weak recommendation with moderate evidence for adults with sepsis, septic shock, and who have risk factors for GI bleed. We suggest using stress ulcer prophylaxis. So the important landmark trial that came is the stress ulcer prophylaxis trial, this SUP ICU trial. So it did not show any mortality benefit, but there was a decreased clinically significant GI bleed without increase in any infections, because they say there could be an increase in VAP with inadvertent use of pantoprazole, and there was no serious adverse effects. So this suggests a potential benefit of pantoprazole in selected critically ill patients with multiple risk factors for GI bleed. And also, its use reduces the risk of clinically important GI bleed when compared to placebo, with a risk reduction of 1.7%. So, what are some of the approved indications for stress ulcer prophylaxis in our ICU? So, patients in mechanical ventilation more than 48 hours, patients with coagulopathy, traumatic head injury patients with GCS of less than 10, burns patient with more than 35% involvement of the total body surface area, trauma patients with high injury severity scores, spinal cord injury patients, partial hepatectomy, solid organ transplant patients, and patients on antiplatelets. Okay, so these are, and also patients on steroids and prolonged ICU stay, then these are risk factors for stress bleeding, and in these patients you have to use the stress ulcer prophylaxis. Coming to venous thromboembolism prophylaxis. So for this is a very high grade recommendation. So for adults with sepsis or septic shock, we recommend using pharmacological venous thromboembolism prophylaxis unless a contraindication to the therapy exists. Supposing it's an ICH or patient is having a variceal bleed, unless and until there's a strong contraindication, all ICU patients have to be covered with the pharmacological venous thromboembolism prophylaxis. For adults with sepsis, septic shock, we recommend using low molecular weight heparin over unfractionated. So there is a liking towards low molecular compared to unfractionated in the guidelines. And for patients with septic shock, we suggest against using mechanical prophylaxis, mechanical like intermittent pneumatic compression or stockings. So in addition to pharmacological, you don't have to use it. There is not much role. So the incidence of DVT in ICU itself ranges around 10%, and the incidence of pulmonary embolism is 2 to 4%. So though there are no major RCTs to say venous thromboembolism is effect or mortality benefit, it is a cost-effective intervention that can be done at the bedside. So pharmacological venous thromboembolism prophylaxis is given to all the patients. Again, there are no studies to say low molecular has superiority of unfractionated, but there were few studies that said that low molecular had a better incidence in preventing DVT compared to unfractionated. And also the ease of using low molecular, it is a OD dose, so much easier for patients to use compared to unfractionated. So the prevent trial showed no mortality benefit of intermittent pneumatic compression devices versus intermittent pneumatic compression along with pharmacological prophylaxis. So no point of using both. Why? Because though it does not cause harm, it comes with a cost, and there is resource implications. It's not available everywhere, and of course it does not change into any patient outcome. So it's not recommended by the Surviving Sepsis Guidelines. Coming to renal replacement therapy, in adults with shock and AKI, we suggest using either continuous or intermittent. So there is no superiority of one or the other. And with no in septic shock patients in AKI with no definitive indications for RRT, we suggest against using RRT. So unless there are definitive indications like uremia, refractory metabolic acidosis, hyperkalemia, and we cannot use RRT unnecessarily in the ICU. So there are no meta-analysis to support intermittent versus CRRT. There are some few RCTs and studies, but there is no meta-analysis to prove the superiority of one or the other. Then the ideal ICU trial in patients with septic shock and severe AKI, there was no difference in mortality for patients assigned to an early compared with a late strategy for RRT. So early versus late, there is no mortality benefit. Start AKI, that was one more trial, even that did not show any mortality benefit in the timing. So early versus late is still debatable, but unless there's an indication, RRT should not be initiated. Coming to glucose control, this is a strong recommendation, moderate evidence. For adults with shock, we recommend initiating insulin therapy at a glucose level of more than equal to 180 milligram per DL. So even the American Diabetic Association recommendations in critical ill, they say you have to initiate insulin therapy for a persistent hypoglycemia, more than 2 readings of 180 milligram per DL, and thereafter you have to target a glucose range of 140 to 180. So, but a tight glucose control, there are more episodes of hypoglycemia, and there is some role of tight glycemic control in the surgical ICU compared to the medical ICU. In medical ICU, in fact, the mortality is much higher. Compared to also one important landmark trial is a nice sugar trial. So here, a blood glucose target of less than 180 resulted in lower mortality than a target of 80 to 108. And hence, the authors did not recommend the use of low target in critically ill patients. So around 180 to 200 would be the ideal cutoff than going for a more tight glucose control. Coming to vitamin C, so for adults with sepsis or septic shock, we suggest against using IV vitamin C. So they have removed vitamin C. Lot of hue and cry about vitamin C, but finally there is no role of vitamin C in septic shock. So initially, this is a Marek study. It was a single center study. That's how vitamin C came into being. That showed lower mortality and shorter vasopressor therapy before after therapy, and everywhere Marek protocol people started following it. Then came the citrus alley trial. In between, there were many trials. I just mentioned the important trials. There was no significant difference in the SOFA, the organ dysfunction, with the use of vitamin C. Of course, there was no mortality benefit anywhere, but even then, even secondary outcomes, there was not much any benefit. Compare in vitamins trial is one more trial in patients with septic shock. Treatment with IV vitamin C, hydrocot, and thiamine compared with IV hydrocot alone did not show the improvement in the duration of the time alive and free of vasopressor administration of 7 days. That also did not show any benefit. Then the ACTS trial, that is ascorbic acid steroids thiamine trial, that also did not result in a statistically significant reduction in SOFA score during the first 72 hours. Coming to the bicarbonate therapy. So for adults with septic shock and hyperperfusion-induced lactic acidemia, we suggest against using bicarb to improve the hemodynamics or to reduce the vasopressor requirement. So there is not much role for bicarbonate in lactic hyperperfusion, which induced high lactic acidosis. But for adults with septic shock and severe metabolic acidosis, wherein the pH is less than 7.2 and there is AKI, there is the role of sodium bicarbonate therapy. Coming to the BICAR ICU trial, this was a landmark trial. There was no difference in 28-day mortality, but in subset of patients with AKI, lower mortality was observed. Okay, so you can use bicarb, especially if pH is less than 7.2 in patients with AKI, then you can use bicarb, but there is no role of bicarb in lactic acidosis. Coming to nutrition, for adult patients with sepsis or septic shock who are fed enterally, we suggest early initiation of enteral nutrition, that is within 72 hours. Early is defined as less than 72 hours. Why? Because it helps in maintaining the gut integrity, it prevents bacterial translocation, it intestinal permeability is not increased, it dampens the inflammatory response, and it modulates the metabolic response that can reduce the insulin resistance. Of note is important is a Nutriria 2 trial. So in this trial, early enteral nutrition and early parenteral nutrition did not differ with regards to major clinical outcomes. So if the gut is viable and patient shock is minimal, you can go ahead and start early enteral nutrition. Then the 2021 also recommendations also they came out with long-term outcomes and goals of care. I'll be talking only about the best practice statements because there are many statements. The best practice statements that have been given are: for adults with septic shock, we recommend discussing the goals of care and prognosis with patients and family over no such discussion. So earlier we have to prognosticate with families. Then another best practice statement, we recommend that the principles of palliative care be integrated into the treatment plan when appropriate to address the patient and family symptoms and suffering. So whenever you feel that there is futility of treatment or there is a role for palliation, then the palliative care team should be involved, and also family should be involved in the discussion. For adult survivors of sepsis or septic shock and their families, we suggest one more best practice statement is: for adults with sepsis or septic shock and their families, we recommend screening for economic and social support and make referrals where available to meet these demands. So we have to look at the economic and social support or social background of these patients also. And another best practice statements is: we recommend the clinical team provide opportunity to participate in the shared decision making in post ICU and hospital discharge planning to ensure discharge plans are acceptable and feasible. So family also should be involved, and also the different clinical teams that are involved in the care also have to be involved. Then for we recommend reconciling the medications at both ICU and hospital discharge. Very important. So reconciliation of medicines prior to discharge and prior to shift to ward, very important. Also, we recommend including information about the ICU stay, the sepsis and related diagnosis of the patient, treatments, common impairments after sepsis in the written and verbal hospital discharge summary. So that should be clearly mentioned, and information should be given out. And we recommend hospital discharge plans with follow-up with clinicians to support and manage new and long-term sequel. So for follow-up, we have to support these patients. And for adult survivors, we recommend assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge. Many of these patients have PTSD. So physical, cognitive, and emotional support has to be given to these patients. So this is about the surviving sepsis guidelines. I'll just add a few slides on the criticism of the surviving sepsis guidelines. So some pros is they said that it's a good literature summary. The grade system was involved. That is a recommendation. The grade system was inculcated, and that gave more clarity regarding the guidelines. International panel of expert with a wide diversity of gender and geographical distribution. There was no evidence of harm from the use of SSG. So all the guidelines which were used, there was no harm intended for any patient. Early antibiotics always is a good evidence to back it. These were some of the pros. The cons are the bundles magnify ineffective therapies sometimes, and the grade system is more subjective. Okay, how do you say it's high? It's a weak recommendation, strong recommendation, and most recommendations are based on low grade evidence. So there are only few high, strong recommendations. Majority are weak recommendations, and there's no evidence for any bundle synergy. And there is too much emphasis on the EGDT, the early goal-directed therapy, which was the pioneer paper for the furthest trials. And the ANZICs did not endorse it. That is the Australia New Zealand Intensive Care Society never endorsed the survival sepsis guidelines. Even the IDSA did not endorse the Surviving Sepsis Campaign guidelines, that is the Infectious Disease Society of America. They had a few pointers to say why they don't endorse the Survival Sepsis Campaign guidelines. I have an article on that. I have pinned it later. So they said that it's failure to acknowledge the practical difficulties clinicians often face when trying to diagnose sepsis. So it is easy to say diagnose sepsis, but in the time frame, it is very difficult. It does not differentiate between patients with suspected sepsis and suspected septic shock. So there is no clarity on that. And stipulating an aggressive fixed time period from the time of recognition may lead to unintended consequences, namely increased likelihood that broad spectrum will be given more frequently to uninfected patients with syndromes that look like infections in the rush to meet the time frame. This 1 hour, 3 hour, which we talk about in the bundle and the guidelines, that kind of puts stress on the clinician and the bedside nurses, and also inadvertent use of antibiotics it can result in. They do not define how time to antibiotics is measured in terms of either a starting point or end point. Time to antibiotics, time from what? Time from the first fever, or from the time of point of care, from the time he came to the ED, or when he first met the clinician. So that point, the starting point or the end point, has not been clearly defined. Then they do not address whether to draw blood cultures from all the catheters and all the lumens, and how to prioritize catheters if there are multiple catheters and lumens in place. So supposing there's a hemodialysis catheter and a central line, there's an arterial line, which has to be removed first, how to draw blood, which catheter you would prefer. So that clarity is not being given in the surviving sepsis guidelines. Guidelines should have clearly mentioned removing catheters in patients with refractory shock, hard to treat organisms, or persistent. So he just states that you have to remove the catheters, but they do not suggest when what are the specific scenarios when you have to use, when there is shock or some resistant organisms. So that clarity is not there, and the recommendations for optimizing pharmacokinetic and pharmacodynamics are also lacking in specifics. So this is the article. It's in 2018. Actually, the majority of the criticism was for the 2016 guidelines. The 2021 has taken into account few pointers and come up with updated guidelines. But still, I think the next future guidelines, we will see more reforms come into place. So I would like to conclude by saying, as they have mentioned in the starting of the guideline itself, the recommendation from these guidelines cannot replace a clinician's decision-making ability when presented with a unique patient's clinical variables. And these guidelines are intended to reflect best practice. So they should not be taken as a norm. So every patient, we have to look individually and then decide upon the further course of action. So thank you.
Thank you, Dr. Sapthami, for that extensive presentation. I think apart from the surviving sepsis guidelines, also you had given really good emphasis on the important trials and how to take decisions. So, on occasion of World Sepsis Day, if you want to give one message to all the intensivists based on your experience, what would it be?
Sepsis can be prevented. Sepsis education is required not only for clinicians, for the bedside nurses, the lay persons also. So we have to follow the 1 hour bundle. If not with the time constraints, it should be followed judiciously for all the patients. And sepsis should always be kept in mind. We should be sepsis minded in the ICU, because that is one differential that comes for every patient. And yeah, by following these guidelines, we can prevent sepsis in our ICU.
I think, like rightly said, it's about a team effort, and all of us have to be on the same page. We need to be sepsis minded, and also the local practice determines everything. So, guidelines cannot be implemented to each setup. So, I think it's important to have local policies on what is best for our independent settings. So, thank you, Dr. Sapthami, for this wonderful presentation on guidelines. We'll close the session with this. Thank you very much.
Thank you so much. Thank you.